posted for congenital hydrocele repair, sir. And child had a history of cough with fever 2 weeks ago, treated by pediatrician and given clearance, sir.
Clearance. What are the challenges or problems in this case?
Recent recent URTI and pediatric age and
so first is pediatric age group patient with
yes,
all
sir.
the problems of pediatric anesthesia. Okay.
Yes, sir.
Second is the patient had a recent episode of LRI. So pediatrician has given clearance, but we must also make sure that the child has completely recovered. So the common question is, what are the causes of LRI in a child?
Infections, sir. Bacterial and viral infections.
Very good.
Most common bacterial infection, gram-positive streptococci, sir, and pneumococcus, and gram-negative E. coli and Klebsiella. Viral infections like
Haemophilus influenza.
influenza, sir.
So common is viral infection. So how many weeks or days you should wait for the child to fully recover if they have developed a viral respiratory infection?
For elective cases, we'll wait up to more than 6 weeks. Will be
6
better
weeks,
option.
minimum 6 weeks. Okay.
Okay, sir.
Very good. So that is the time that you have to do. What is the danger if you take the child before that period of 6 weeks?
If instrumentation of airway will flare up the
It's a hyperreactive airway. The answer you have to give is it may be a hyperreactive airway. So any instrumentation or intubation will flare up the airway and cause spasm and secretions and edema, all these things. Okay. So these are the three dangers. It can produce bronchospasm, laryngeal spasm. It can produce a lot of secretions and obstruction, or it can produce edema. That is why we don't want to irritate that reactive airway. Okay, right. So now, how are you going to give anesthesia? The surgeon has fixed up the surgery because the pediatrician has given clearance for this child. So how are you going to proceed? He has sent the baby to you for assessment.
Pre-operative evaluation and pre-op optimization, sir. Pre-op evaluation history, detailed history of physical examination, detailed history of patient history of any fever, cough, and cough, cold, and if it is cough, productive cough since how many days, duration, and last episode.
Always in a pediatric patient, 1 year old or less than 1 year old, how do you start with the history taking?
Birth history, sir.
Birth history. You must always start from the birth history. Why birth history is important? Supposing this child is born as a premature baby.
Yes, sir.
Is there any relevance to this?
Preterm babies is more prone to infections, sir, and some area anomalies.
Holding, sir.
It's called breath holding. It's called apnea of prematurity. Okay,
Yes.
Apnea of prematurity. They are more prone for what is called apnea of prematurity in the post-operative period. They can have apnea, which may cause desaturation, bradycardia, and arrest. Okay, so that is a very important post-op complication. So that is why you must always start with the birth history. The patient, the baby was born as a full-term baby or a premature baby, whether any neonatal ICU admissions were there, any issues which are relevant to the birth is very, very important, and whether this hydrocele has been present from birth or detected later on. Because congenital hydrocele usually happens right from birth because of the developmental anomaly. So as I told you earlier, if there is any congenital issue, you should always look for any other congenital anomaly present in the baby. Okay. So after that only you must ask, when was the episode of fever and cough? Now the pediatrician has said the child is fit and clear. So that means he is not a fool. He would have seen and made sure that the child lungs are clear and the patient has had a good course of antibiotic and fever has subsided and patient has regained normal eating and playing, and he has given the clearance. But what is your concern? How will you rule out there is no residual infection present in the patient?
Auscultation with history and auscultation, sir. Many crepes or wheeze.
See, pediatrician has given clearance saying there is no Krebs. But do you do any particular specific test to find out whether there is any occult or residual infection? That is my question.
You'll ask the patient to cough.
1 year old, will you ask him to cough? Will he be able to do?
Stimulation of the supraesternal not
It is called carinal stimulation. Okay, you must do what is called post-carinal stimulation auscultation. So you cannot ask or instruct a 1 year old baby to do coughing. So you put your finger in the suprasternal notch and rub over the trachea. That will stimulate the carina and patient will automatically develop a cough. I think I have told you all these things in the class. In a recent respiratory infection case, always in pediatric patient, you must do this routinely to develop, see whether they develop a cough which is more productive in nature or phlegmy. Okay, if there is any residual infection, in silent breathing, the lungs may appear to be very clear without any crepitations. But once you do this carinal stimulation and make the baby cough, this post-tussive auscultation may relieve the peripheral crepitations and it will bring the occult infection outside. So that is what you have to do routinely in all these cases. And if it is still present, this being an elective surgery, you can postpone it for some more time. Give the child some more bronchodilators, some mucolytics, and try to clear that whatever hidden infection is there or secretions are there, and then take up the child when the post-tussive auscultation is also giving you a clear crepitation-free air entry. Okay, that is a safe method of taking up this child for surgery. Okay, so that is the one important point that you have to make out. Right. In spite of, so you do the post-carinal stimulation auscultation and there is no crepitations found. That means the lung is quite clear. Now, what is your choice of anesthesia for this surgery?
As it is a lower abdomen surgery, short GA with caudal block, sir.
What do you mean by short GA? Examination saying this short GA, long GA,
GA with
bag.
GA with bag and mask ventilation, or GA with supraglottic airway device, or GA with ET tube.
So you want to put an ET tube in a patient who has recently recovered from this respiratory infection?
No, sir. This is an option.
So then why do you say that? This is the catch in the question itself is try to see whether you will avoid endotracheal intubation or stimulation of the airway. Okay, that is the purpose of giving such cases. So in that case, if you commit that you will put an endotracheal tube, that is not at all appreciated. Okay, you have to omit that answer at all completely. I will try to, as far as possible, I will try to avoid any airway instrumentation, laryngoscopy or putting a tube. Okay, so even supraglottic airway is comparatively safe, but even that can be avoided. So bag mask ventilation is a technique which can be safely done without any problem. But if you want to do bag and mask ventilation and give caudal, what is the problem in that? Can you do it as a single person?
No, sir. With two supports will be there. One should hold the baby.
Somebody else to help you, isn't it? To keep the child under, somebody must hold the mask, and that person should be knowledgeable enough to hold the mask for a pediatric case. You cannot give it to a new first year sister or a theater boy and try to do that. That will be very risky. Okay. So what is the other alternative where you can, as a single person, do the caudal without any difficulty?
IV sedation, sir. IV sedation or IV sedation, sir.
IV sedation. With what?
Ketamine, sir. Better prefer
Why not you give
ketamine,
it
sir.
intramuscular? Why do you want to give IV? Even before 1-year-old child, what is the other problem? Will it come off easily from the mother?
Yes, secretions is a major problem, sir.
No.
Sir.
1-year-old baby held by the mother, can you just like that bring that baby into the OT?
No, sir. Difficult to separate from the mother, sir.
What is that called? Separation anxiety. Okay.
Okay,
So
sir.
the child, because 1-year-old, it will not come from the mother, it will cry. So you can give intramuscular ketamine with an glycopyrrolate or atropine, which will control the secretion. So secretion is not a major problem in intramuscular injection. Okay? So what
Okay,
is the
sir.
dose you can give intramuscular ketamine?
0.5 mg per kg, sir.
Okay. 0.5 mg intramuscular, will it act? 0.5 mg is the IV dose, even for
Okay.
sedation.
1 to 2 mg per kg, sir.
3 milligram per kg body weight is the intramuscular dose, what is called the stunning dose of ketamine. It will not produce total anesthesia, it will just make the child dazed. It will not know whether it is in the mother's hand or father's hand or in the theater sister's or by theater boy's hand. Okay, that's called the stunning dose, which is 3 milligram per kg. Anesthetic
Okay.
dose of ketamine intramuscular is 5 to 10 milligram. Intravenous dose of ketamine is 0.5 to 1 or 2 milligram maximum. Okay, so these doses you should not make any mistake, you should know them thoroughly. Okay, so you can give 3 milligram per kg. For a 10 kg child, you can give up to 30 milligram intramuscular IM with glycopyrrolate or atropine, 20 micrograms per kg, and wait for about 5 to 10 minutes. So how do you know that the ketamine has started acting before you pull the child from the mother?
Will observe nystagmus, horizontal nystagmus.
Yes. The onset of action is indicated by nystagmus of the eye ball, and that is the time you can easily separate the child from the mother and bring it inside and then start your IV line, and then you can put the baby in lateral and start giving your caudal. So you must know everything about caudal. What is the anatomical landmark for giving a caudal block?
S4, S5 space will be there, sir.
Anatomical landmark means you must say the bony landmarks which you are able to palpate and then identify.
Sir, the cornea of the sacral cornea, sir.
Sacral cornea, very good.
We'll palpate the sacral cornea and hiatus. We, will inject the needle 45 degrees perpendicular 45 degrees to the skin, and after piercing the sacrococcygal ligament, will decrease the angle to around 30 degrees, and after a fine aspiration without any CSF or
45
any.
degrees you are starting, you decrease it to 30 degrees. That means you are just
Yes,
increasing only by 15, or you should make it flat, parallel to the skin.
Yes, parallel to the skin. And we have to insert some little more, and
How
we
do you
have
know
to.
that you are in the caudal space after inserting the needle?
There is a test called Hush test, by ausculting the space with the diaphragm of the stethoscope. If we inject the air once 1 or 2 cc, we'll hear the
So it's a
push
very
sound,
old
sir.
test which is not accepted nowadays. Nobody prefers to do that. It is not agreed as a confirmative test, and people don't accept that as that. But simple loss of resistance. Okay. So
Okay.
you keep 2 ml or 3 ml of air in the syringe and push it. If it goes easily with the pressure of your little finger, then that means it is the space. Okay, you should not
Yes.
use your regular way of holding the syringe like this and pushing. You should use your little finger and push the piston. And if that force is enough to push the air into the epidural space, that is more than enough. Okay, that is a confirmatory evidence of the drug being inside the. And when you inject the local anesthetic, you should not see any bulge in the subcutaneous area. That means that the
Yes.
needle has gone subcutaneous. And your loss of resistance also will not be appreciated if the needle is subcutaneous. What other location the needle can go? When the needle, you will not appreciate the loss of resistance.
The intravascular subarachnoid space
Intravascular
will.
means you will get blood, isn't it?
Yes,
Always
yes,
if
sir.
you have gone intravascular, there will be bleeding. Periosteal. Okay, many times you go very posterior and you can go into the periosteum of the coccyx bone. Okay, so that is another location where it can get involved. So what is the volume you have to give? What is the concentration of local anesthetic? What local anesthetic you prefer to give?
Okay, sir. 0.25% bupivacaine, sir.
Very good.
It is a lower abdomen surgery, so preferred is 0.5 mg per kg, sir.
Point surgery for sacral, for circumcision and other things. You say lower abdomen, is it 0.5 enough? Hermitage formula?
Sir. 0.75 mg
0.5
per kg.
only for sacral block. Okay,
Okay,
the
sir.
S2, S3, S4.
0.75 mg.
Whereas what is the block that you require for a congenital hydrocele? Even though it is hydrocele, where is the incision made?
On the scrotum, sir.
It is not on the scrotum like an adult. Congenital
Inguinal,
hydrocele.
inguinal.
It is a inguinal. You have to identify the continuation of the sac and ligate it and then remove it from the scrotum. Okay, so it is not like an adult you make a scrotal incision. It is made in the inguinal region. So you require a block up to L1, L2.
L1.
Ilioinguinal, iliohypogastric nerves to be blocked. Okay, so for
Okay,
that,
sir.
what is the volume you require?
0.75 mg per kg.
1 ml per kg body weight. Okay, 1 ml per kg body weight. So that is the minimum. Hermitage, sacrum 0.5, up to umbilicus 1 ml, above umbilical 1.5, and 1.5 you reduce the concentration and you want a higher block. Okay, so 0.25, then you can go to 0.2 and you can even go to 0.15. Like that, you can reduce the concentration but give higher volume to achieve a higher level of blockade. Okay, so that you
Okay,
must
sir.
read and remember all that various dosages and concentration, and you can complete the surgery with the caudal anesthesia itself. On the contrary, if you are worried about how do you know that the caudal is active when you are given ketamine and sedated the child, how do you find out whether the caudal you are given is effective or not in a male child? Will you straight away allow the surgeon to proceed with the surgery, or you have to check whether your block is effective or not?
Cremator reflex.
Excellent. So you, how do you do the cremasteric reflex?
Uh, in the in thigh, if we scratch that
Inner
chromatic
aspect
reflex,
of the thigh, within the medial aspect of the thigh, just make a stroke, rub with your finger. Then if the scrotum is not contracting, that means the cremasteric reflex is absent and your caudal block is perfectly well working. Okay, that is the way to find out in a male child. Supposing it is a female child, of course they may not get develop a congenital hydrocele. Supposing they have a inguinal hernia, how will you know whether the caudal is acting or not in a female child?
no ideas.
Vinita, Nandini, Pavitra, Pratik Shukla.
Deny direction.
Female child,
Okay.
madam. I'm asking about female
There is a
child
voice
having a caudal block, how to test the efficacy of the block. I'm not talking about a transgender. I'm talking about a female child. Huh? What is below the vagina in a child?
Anal sphincter.
Anal sphincter. Will it act or relax?
Contract, sir.
It will be relaxed. Okay, there is no, that normal anal sphincter contraction will not be there in a female child or male child also. So in a female, you can just lift the leg and see whether the anal sphincter is relaxed. That corrugation will not be there. Whereas in a male child, you can test for the cremastic reflex. Okay, that is how. So it is very important that you make sure that your caudal is working well before you allow the surgeon to paint, drape, and start the surgery. Otherwise, if the caudal is not taken up well, the child, when the surgeon puts the incision, the child can go in for laryngospasm or bronchospasm. Okay, all these complications can happen. So that is very important. So again, I will just show you a presentation of the salient points what you have to remember in this case.